Hi students, I'm a teacher from pediatric surgery. My name is Pavlo Vladimirovich Oshchensky from Pediatric Surgery and Children's Diseases Department. Today you have a second lecture, Purulent-inflammatory diseases of abdominal cavity. The plan of our lecture includes acute appendicitis, cholecystitis, and acute pancreatitis. Acute appendicitis. First of all, fresh in your mind relevant anatomy of it. The appendix, it's a worm-like extension of the cecum, and its average length is 8 to 10 centimeters. It appears during the 5th month of gestation. The convergence of Taenia coli is detected at the base of the appendix beneath the Bowgen valve. Structure of the appendiceal wall. First of all, figure A1, it's a mucosal layer. Lymphoid follicles are scattered in its mucosa. Its number increases when individuals are aged 8 to 20 years. 2A, inner muscular layers, which are secular. 2B, outer muscular layer, they are longitudinal, derives from the Taenia coli. 3, it's a serosa, and mesoappendix. Appendix artery is scattered here. Stages of appendicitis. Early stage, suppurative appendicitis, gangrenous appendicitis, perforated appendicitis, phlemonous appendicitis, or abscess. In early stage of appendicitis, obstruction of the appendiceal lumen appear. It's caused by many factors, especially lymph nodes hyperplasia or lymphoid structure hyperplasia, may be obstructed by worms, helminths, and phacolids, and so on. Then it caused mucosal edema, mucosal ulceration, diapedesis of bacteria, then distension of the appendix due to accumulated fluid, and increasing intraluminal pressure. In suppurative stage, the appendiceal wall grossly appears thickened, the lumen appears dilated, a serosal exudate may be observed as granular roughening. At this stage, mucosal necrosis may be observed microscopically. In gangrenous stage, intramural venous and arterial thrombosis ensure, resulting in gangrenous appendicitis. Microscopy may demonstrate multiple microabscesses of the appendiceal wall and severe necrosis of all layers. Perforated appendix, when persistent tissue ischemia results in appendiceal infarction and perforation. Perforation usually occurs at the antimesenteric border. And phlemonous appendicitis or abscess, and inflamed or perforated appendix can be walled out by the adjacent greater omentum or small bowel loops, and phlemonous appendicitis or focal abscess occurs. At this picture, you see the difference between omentum of the adult and of the child. In the child, it's rather smaller, and it cannot cover the inflamed appendix. That's why the peritonitis spread very quickly. Appendicitis occurs in all age groups. The mean age in the pediatric population is 6-10 years. The mean age is 6-10 years. Appendicitis is rarer in the neonate, and the diagnosis in this age group is typically made after perforation because clinics is aspecific. Only distension of the abdomen, temperature instability, vomiting, and signs of perforation with quick, very fast. Younger children have a higher rate of perforation with reported rates of 50 to 85%. Male to female ratio is approximately 2 to 1. The bacterial flora of appendices is derived from organisms that normally inhabit in the human colon. They are Bacteroides fragilis, a gram-negative strict anaerobe, Escherichia coli, a gram-negative facultative anaerobe, other anaerobic species such as Streptococcus, Pseudomonas, Klebsiella, and Clostridium. Typical position of appendix, it's a Mark-Bournet point. It's a two sets of way between umbilicus and anterior superior iliac spine. And pain at these points during palpation is named Mark-Bournet sign. But the type of position may be in constancies, a very different position. It may be retrocecal, a retroperitoneum, it's behind the cecum, pelvic, subcecal, post-ilial and pre-ilial, paracecal, even in the left iliac fossa. In neonates who has problem with intestinal rotation, mostly the cecum can be identified in the right hypochondrial region. That's why appendix situated also here. It may be such pathology as omphalocele, gastroschisis, diaphragmatic hernia, and so on. The classic presentation of the appendicitis observed in 60% of cases with fever. They are periumbilical pain at first, which is migrate in the right lower quadrant in the past 24 hours. Nausea and vomiting. Vomiting appear after the pain. Anorexia. Abdominal pain precedes vomiting, low-grade fever, and signs of peritoneal irritation and muscles deafness. Clinical features of appendicitis in neonates. It's irritability or lethargy, abdominal distension, vomiting, a palpable abdominal mass, cellulitis of the abdominal wall, diffuse tenderness of abdominal wall, maybe edematose of external genitalia. During physical examination, such patients walk slowly, often humped forward, protecting the right side. The right hip frequently is held in slight flexion. Fever, tachycardia, and signs of dehydration quickly increase. Typically, maximal tenderness can be found at Mark-Bournet point. Guadin may or may not be present. Signs of the appendicitis. Cough sign. It's a sharp pain in the right lower quadrant after voluntary cough, named Dunphy sign. Rebound tenderness related to peritoneal irritation elicited by deep palpation with quick release. It's a Bloomberg sign. Pain in the right lower quadrant in response to left-sided palpation, arousing sign, operator sign, and ileophilic sign. This picture demonstrates how made rousing sign. It's a pain in the right lower quadrant in response to the left side palpation. It's due to cecum dilatation. Retrocecal appendicitis. You see it's behind the cecum. the clinical presentation rather different because inflammation spread to the lumbar muscle. A child walks with exaggerated lumbar lordosis and have a slightly flexed right hip. Pain with extension of the right hip with the patient in the left lateral decubitus position, psoas sign, and with internal rotation of the thigh, its obturator sign in pelvic presentation. When a ped is situated in the right paracolligata, typically results in flank pain, mimicking acute pyelonephritis or ureteral calculus. Symptoms resembling those of gastroenteritis may result from colonic irritation. It's a rotor sign, digital rectal examination. You can feel the abscess formation and the Douglas pouch and some elevation of anterior rectal wall. And this investigation is pain. In lab studies, pay attention for white blood cells count, which is elevated in approximately 70–90% of patients, more than 10,000 leukocytes, neutrophils, more than 75%. Other analysis, such as urine analysis, electrolytes, serum lipase, or bilirubins, we use for diagnosis of acute appendicitis. Such urinalysis presence of over 20 white blood cells suggests a urinary tract infection. Also, if present fresh erythrocytes and epithelium cells, which show us nephrolithiasis, electrolytes and renal function in children with significant history of vomiting or clinical suspicion of dehydration. To correct this problem, electrolyte disturbances. Additional studies such as liver function tests, serum amylase and serum lipase may be helpful when the etiology of the abdominal pain is unclear. To differentiate with cholecystitis, cholestasis, pancreatitis, urinary levels of human chorionic gonadotropin metasabolite in sexually active adults and females to exclude ectopic pregnancy, and in new guidelines to acute appendicitis, the all females older than 10 years, this analysis must be done. Imagine studies, the first steps for evaluation must be ultrasonography. Advantages of this method: it's non-invasiveness, short acquisition time, lack of radiation exposure, and potential for diagnosis of other causes of abdominal pain. Disadvantage is ultrasonographic examination is operator dependent. In adolescents, also in female, this investigation must be done to differentiate with gynecological problem. The second level of investigation is a computer tomography and MRI, which must be done with intravenous contrast. Advantages of this procedure is a superior sensitivity and accuracy compared with other imaging techniques, ready availability, non-invasiveness, and potential to reveal alternative diagnosis. And the main disadvantages is radiation exposure. Potential for anaphylactoid reaction if intravenous contrast is used, lengthy acquisition time if oral contrast is used, and patient discomfort if rectal contrast is used. Ultrasonographic signs of the inflamed appendix. First of all, we must know the measurements in figure. Its diameter more than 6 millimeters, wall thickness more than 2 millimeters, non-compressibility, lack of peristalsis, presence of periappendiceal fluid collection, or abscess formation. Acute appendicitis, we must differentiate with imagined surgical diagnosis, imaginal non-surgical diagnosis, and other diagnosis. Imagined surgical diagnosis is intestinal obstruction, malrotation, intussusception, Meckel's diverticulum, ovarian torsion, ectopic pregnancy, other diagnoses with which we must differentiate. It's also gastroenteritis, mesenteric adenitis, distal ileitis, cecal cancer, salpingitis, and urinary tract infection. Also, don't forget about testicular torsion in males, pharyngitis, maybe primary peritonitis, and omentum torsion in the complication of acute appendicitis. They are perforation, peritonitis, which may be local and diffuse in general, abdominal sepsis, and dehiscence. Maybe pylophlebitis. It nowadays is not so common. Operative details. Routine laboratory and radiological studies must be done, venous access, fluid resuscitation, and if necessary, the abdomen is washed, antiseptically prepared, and then dropped. Before appendectomy, we can use one dosage of antibiotics, that is 60 minutes before operation. If high temperature is present, maybe paracetamol 15 milligrams we use. Access. If we use open appendectomy, it requires a transverse incision in the right lower quadrant over the McBurney point. It's a 2/3 of the way between the umbilicus and the anterior superior iliac spine. The vertical incision, buccal pararectal, are rarely performed because of the tendency for dehiscence and herniation. The abdominal wall fascia and the underlying muscular layers are sharply dissected or split in the direction of their fibers to gain access to the peritoneum. The peritoneum is open transversally and entered. The cecum is identified and medially retracted. The convergence of tunicula is detected at the base of the appendix. Then mesoappendix is held between the clamps and divided in ligation to prevent bleeding. Then appendix is clamped approximately about 5 millimeters above the cecum to avoid contamination of the peritoneal cavity and is cut above the clamp by a scalpel. It's a classical antegrade appendectomy if you can't see the tip of appendix, use retrograde appendectomy. It begins from the appendix base. Then appendix may be inverted into the cecum with use of persistent suture or ligation methods, only ligation of the appendiceal stumps in younger patients. How look like inverted appendiceal stumps into the cecum. The cecum is placed back into the abdomen. The abdomen is irrigated. Wash the abdominal cavity if a is present or some free fluid is present, then sucked it. When evidence of reperforation exists, peritoneal lavage with several liters of warm saline is recommended, and obvious abscess with gross contamination requires drainage. Then close the wound. First of all, close the peritoneum with a running suture. The fibers of the muscular and fascial layers are reapproximated and closed with a continuous or interrupted absorbable suture. The skin is closed with subcutaneous sutures or staples. Indications for surgical treatment of appendicitis. You know the three ways of appendectomy. It's open appendectomy, totally laparoscopical appendectomy, and maybe combination of these two methods. It's abbreviation TULA, transumbilical laparoscopically assisted appendectomy. Which indication for laparoscopic appendectomy? It's a female of reproductive age group. If female of premenopausal group suspected appendicitis for diagnostic procedure, high working class, obese patients, disease conditions like cirrhosis of liver and sickle cell disease, and immune-compromised patients. Open appendectomy indication in complicated appendicitis, if cardiac disease present, generalized peritonitis, previous low abdominal surgery, hypercoagulable states, and stump appendicitis after previous incomplete appendectomy. Laparoscopic approach has following advantages. Diagnostic advantage in female of reproductive age group. It's cosmetically better outcome, less tissue dissection and disruption of tissue planes, less pains postoperatively, low intraoperative and postoperative complications, and early return to work. Position. Total 3 trocar should be used. 2 10 millimeters umbilical and the left lower quadrant trocar, and 5 millimeters right upper quadrant trocar. The right upper quadrant trocar can be moved below the bikini line in female. Pneumoperitoneum is created in the usual fashion. 3 ports are used in traumatic grasp is inserted via the right upper quadrant trocar. The cecum is retracted upward towards the liver. In most cases, this maneuver will elevate the appendix in the optical field of the telescope. Then retraction of the appendix. The appendix is grasped at its tip with a 5 mm glow grasper via the right upper quadrant trocar. It is held in upward position. Left lower quadrant grasper is used to create a mesenteric window behind the base of the appendix. A dolphin nose grasper used to create a mesenteric window under the base of the appendix. The window should be made as close as possible to the base of the appendix and should be approximately 1 cm in size. You see how made window image of appendix and prepare the base with ligation of appendix. Then appendix is amputated, held by the grasper, and is placed into the spaceman bag. Or if not inflamed, take it out after hiding it inside reducer or cannula itself. Historically, the diagnosis of appendicitis has been made based on clinical findings. Diagnostic imaging has been used primarily to evaluate patients who have an atypical clinical presentation. Over the past several years, improvements in imaging technology have contributed to an increase in diagnostic accuracy in these patients. Early and accurate diagnosis of appendicitis can decrease patient morbidity and hospital costs by reducing the delay in diagnosis of appendicitis and its associated complications, as well as by avoiding inpatient observation prior to surgery in patients who present with atypical symptoms. The next pathology, cholecystitis. You see the normal biliary tract anatomy. The main right and left hepatic duct join to form the common hepatic duct, which joins with the cystic duct to form common bile duct. This common bile duct crosses caudally in the hepatoduodenal ligament along with the hepatic artery and portal vein to the level of the pancreatic head. Major of varieties of gallstones in children. It's divided for composition. It may be cholesterol with calcium salt, cholesterol, pigment, polymer plus calcium bilirubinate. It's a brown pigment stones, calcium bilirubinate plus calcium salts of fatty acids, and calcium carbonate polymorphs. By shape, it's round or faceted, round, smooth, spiky or faceted, ovoid or irregular surface, round or faceted. In color, it may be brown pigment in rings or specks, yellow, white, black, brown, soft, brown, or white. In number, it may be multiple, usually single, multiple, single, or multiple and usually single. It's both sterile, but only pigment stone is infected. Major risk factor: pure cholesterol stones in female gender obesity, black cholesterol stones in female gender obesity, brown pigment in hematological problem, spherocytosis, hemolysis, pigment stones in cholangitis and strictures, and calcium carbonate in children caused by gallbladder obstruction. That's why gallstones in children by etiology can divide it into hemolytic and non-hemolytic gallstones by types. Hemolytic proportion 20-30%, and its etiology is sickle cell disease, hereditary spherocytosis, and thalassemia major. Non-hemolytic type in 40-50% of cases. It's caused by total parenteral nutrition, prolonged fasting, ileal disease or resection prematurity, furosemide therapy, cardiopulmonary bypass, congenital biliary malformation, progressive familial intrahepatic cholestasis, chronic liver disease, cystic fibrosis, and oral contraceptive pills, teenage pregnancy. Idiopathic type, proportion 30-40%, no predisposing factors. Condition associated with acalculous cholecystitis. They are sepsis, hypovolemic shock, burns, trauma, post-cardiac surgery, gastroenteritis, total parenteral nutrition, Kawasaki disease, and typhoid fever. A clinical presentation of gallstones in children, we divided 3 age group. It's infants and children younger than 2 years. Clinical presentation, it's only cholestatic jaundice, transient alcoholic stools, abdominal pain, and sepsis if symptomatic. In asymptomatic patients, it's an incidental detection. In group from 2 to 14 years, typically biliary symptoms seen in 40-50%, and they are right upper quadrant or epigastric pain, with or without nausea, vomiting, and fat intolerance. Non-specific abdominal pain seen in 20-30%, and acute abdomen in 5-10% due to acute cholecystitis, pancreatitis, or cholangitis. 10% are asymptomatic. In adolescents from 14 to 18 years, Clinical presentation is the same as in children, but right upper quadrant pain and fatty food intolerance are more common than in children. Cholelithiasis is readily diagnosed by ultrasound scan in a fasted patient. Gallstones are usually mobile, may be solitary or multiple, and cast and acoustic shadow. Stone size rather than calcium content determines the presence or absence of acoustic shadowing. Gallbladder wall thickness, the diameter of the common bile duct, the liver, and the remaining biliary tree should also be assessed. A stone as small as 1.5 millimeters can be detected by ultrasonography. The sensitivity and specificity of ultrasonography exceeds 95% for gallbladder cholelithiasis, but this figure is only 50–75% for choledocholithiasis. In children, from 20 to 50% gallstones are radiopaquia. This is the ultrasonography, normal gallbladder at the left, figure 1, and gallstones inside the gallbladder. Polyscintigraphy with technetium-99m, labeled disopropyl imidoacetic acid, is the most accurate method of diagnosing acute cholecystitis. Non-invasularization of the gallbladder in an otherwise patient biliary system suggests acute cholecystitis. Magnetic resonance cholangiopancreatography is being used increasingly to investigate complicated gallstone disease. Endoscopic retrograde cholangiopancreatography offers the additional advantage of therapeutic intervention in common bile duct stones. At this CT, cholelithiasis, a densely calcified calcium bilirubinate stone, is present in the dependent part of the gallbladder. The striated renal parenchyma is the result of pyelonephritis. This MRI cholangiogram showing a mildly dilated common bile duct with an obstructing gallstone and stones in gallbladder. You see the management algorithm for gallstones in children. If they are symptomatic, non-calcified, persistent after 12 months of observation, cholecystectomy must be needed. If calcified, also cholecystectomy at first. If symptomatic patient, no improvement after 1 to 2 weeks observation, cholecystectomy might be prescribed. If stone passed spontaneously, only observation, and only observation. If gallstones present in hemolytic disease or symptomatic gallstones in children or symptomatic, such patient needs cholecystectomy. Asymptomatic gallstones in children, observation only. Children with gallstones should be divided into 2 groups. Those with typical symptoms, which are right upper quadrant, or epigastric pain, nausea, vomiting, and fatty food intolerance, should have their gallbladder removed. Asymptomatic children or children with non-specific symptoms can undergo safe follow-up. The children will require observation into adulthood to determine their lifetime risk of developing symptoms. The technique of laparoscopic cholecystectomy has been well described, and operative cholangiogram can be used to clarify anatomy and or identify a common bile duct stone, but the latter is unlikely if the caliber of the common duct is normal and there is no history of jaundice, pancreatitis, or abnormal liver function. Cholangiography can be carried out with a tumor clamp and sclerotherapy needle. Dissection is begun by stripping away the peritoneum to expose the cystic duct and artery. Once the duct and artery are exposed, we apply clips to this structure and then divide them. We advise against using electric cautery here so as to avoid any injury. If there is any doubt as to the anatomy, or if the duct is larger than it should be, or if the preparative studies suggest the possibility of stones and an operative cholangiogram is performed, we do this by clipping the cystic duct as it joins the gallbladder and making a small nick in its wall, large enough to insert the cannula for the study. And the use of a 12-dose plastic catheter as an access port for the cholangiogram catheter and insert this directly through the abdominal wall. We prefer a balloon-tipped catheter as this minimizes the risk for injury, and insert this directly into the duct through a nick in the duct midway between the gallbladder and the common bile duct. Inflation of the balloon holds it in place. The cholangiogram can then be done under fluoroscopic control while the duct is observed to ensure that there is no leak of contrast. If the cholangiogram is negative for retained stones, another clip is applied after the catheter is removed. If the cholangiogram demonstrates stones to be present, there are three options. First, the patient can be opened for exploration. Second, the operation can be completed and the patient referred for postoperative endoscopic retrograde cholangiography. Finally, a flexible endoscope can be used to examine and free the duct of stones, or a pediatric cystoscope can be introduced into the duct for passage of a stone basket. After the cystic artery and duct are divided, a right-angled hook electric cautery device or endoscopic shears connected by two cautery are used to free the gallbladder from its bed. After this is accomplished, the gallbladder bed is inspected for hemorrhage, which is controlled if found. Then move the telescope from its umbilical side to the midline or left subcostal cannula to visualize removal of the gallbladder from the 10 mm umbilical cannula side. When there are stones present, we open the gallbladder and use a stone forceps to remove the stones until the gallbladder can be extracted. The abdomen then is inspected for hemorrhage and lavished if bile has been spilled during the procedure. Then close the fascia for all wounds of 5 mm or greater, or close the umbilical wound to prevent later herniation. All wounds are infiltrated with a long-acting local anesthetic for postoperative analgesia. Patients are awakened from anesthesia and discharged from the hospital when they can ambulate and tolerate liquids, usually on the day of surgery or after overnight hydration in the case of patients with sickle cell disease. The sad pathology for today is acute pancreatitis. Acute pancreatitis is an uncommon disease in children, but has higher morbidity and mortality than in adults. The vast majority of cases of pancreatitis in children are from blunt abdominal injury. In the pediatric population, nearly 40% of cases of traumatic pancreatitis are attributable to bicycle-related injury. After trauma, the most common causes of pancreatitis in children are drug therapy, corticosteroids, azathioprine, thiazides, furosemide, tetracyclines, and valproic acid. Then viral infection, Epstein-Barr, Coxsackie, enterovirus in mumps, and bacterial infection. Cystic fibrosis, biliary disease, vasculitis disease, and type 1 and 5 hyperlipidemias are also associated with acute pancreatitis in pediatric population. Children present with vague abdominal pain, which is exacerbated by eating. The classic symptoms of pain radiating to the back is rarely observed in the pediatric population. Nausea and vomiting may be present. Rarely patients may present with a small bowel obstruction, or young women may present with salpingitis secondary to pancreatitis. In diagnosis, pay attention for serum amylase, trypsinogen, and lipase levels, which are useful to establish the diagnosis of acute pancreatitis. An elevated serum amylase is the usual biochemical abnormality associated with acute pancreatitis. Because amylase production occurs from other non-pancreatic source, elevated serum amylase is relatively non-specific. Calculation of the amylase clearance may be helpful and is normally less than 5%. Trypsinogen and lipase are produced almost exclusively by the pancreas. Elevated serum levels are more specific for pancreatitis. Computed tomography is the best radiographic study to image the pancreas in cases of severe or complicated pancreatitis. Abdominal CT is often obtained as part of the trauma evaluation. Ultrasound is sometimes useful, but often only provides limited visualization of the pancreas due to its retroperitoneal location and interposed bowel gas, which further limits the study. Endoscopic retrograde cholangiopancreatography is an invasive test that can accurately delineate pancreatic ductal anatomy. Endoscopic retrograde cholangiopancreatography causes pancreatitis in 5–10% of cases and is generally avoided during the early phases of acute pancreatitis. Look at this CT. You can see the acute diffuse pancreatitis in mild acute pancreatitis in a 2-year-old girl with Crohn's disease. Portal venous phase CT shows global enlargement of the pancreas with normal glandular enhancements throughout. This patient's symptoms improve substantially within 48 hours. At this CT, you see the acute focal pancreatitis in 2 patients. At picture A, a 9-year-old girl with elevated amylase and lipase levels. Parenchymal phase CT scan shows enlarged, heterogeneously enhancing pancreatic head. Also note fluid in the anterior pararenal space and the root of the small bowel mesentery. At picture B, a 13-year-old boy with abdominal pain, vomiting, and elevated amylase level. Portal venous phase CT shows heterogeneous enhancement of the pancreatic tail. Also note fluid in the left pararenal space and left paracolic gutter. This ultrasonography image shows a cystic dilatation of the biliary duct with intrahepatic duct dilatation and congenital dilatation of the main biliary duct. This diagnosis is confirmed by cholangiography or MRI cholangiography, which shows a common biliopancreatic duct and a high level of amylase and lipase in the gallbladder bile sample. Medical management is the mainstay of treatment for pancreatitis. Volume resuscitation is essential to counter retroperitoneal set space fluid losses. Nasogastric decompression is recommended to avoid gastric distension, and patients are initially maintained nothing per hour with nasogastric decompression. Pain management is essential. Meperidine is preferred because it does not cause sphincter of Oddi contraction like morphine does. Hyperalimentation may be necessary if the course of pancreatitis is prolonged. Enteral feeding distal to the ligament of Treitz via the duodenal feeding tube is the preferred method of providing nutrition in refractory cases. The majority of cases of pancreatitis are self-limited and resolve spontaneously with supportive therapy. In severe cases, necrotitis, pancreatitis, infected pancreatic necrosis, surgical intervention may be necessary for irrigation and/or debridement of the pancreas. The mortality rate in this scenario approached 15%. Thank you for your attention. Goodbye.